We're going to now start with our second lecture. Professor Mittal from Dubai. He's going to give us a talk about STEMI, Care for All, in 2018.
Good evening. It's my real pleasure and honor to be here on this dais. And my special thanks to Professor Brajesh. He said a new friendship. Yes, we developed a new friendship very recently. And I have another friend here in the room, Dr. Peter, with whom our friendship started. So this is a new experience for me to be here in this part of the world. And I have thoroughly enjoyed the last 24 hours. And I would like to share some of my experiences and some of my thoughts of the care of STEMI patients in 2018. So I work in Dubai and I have trained in India. So I'm in Dubai for the last almost 13 years. With this brief background, I'll go forward. And I start with some introduction about the disease as such. According to WHO data, more people die of heart diseases, obviously with acute MIs being the most common cause. And in 2004, approximately 17.4 million deaths occurred due to cardiovascular diseases, which is expected to rise to 23.6 million by 2030. The healthy part is that in the West, the incidence is declining, though in our part of the world, in the Gulf and other Asian countries, it is very high. In fact, in Southeast Asia, we can call it like an epidemic of coronary artery disease. In 2009, US data showed that there is declining STEMI rate, with the STEMI to non-STEMI ratio being 1:2. Interestingly, 30% of STEMI patients have been noted to be women, with a lower perfusion rates, higher mortality and higher morbidities. Approximately 23% patients are diabetic who also have higher mortality. And there is a growing segment of elderly people because the life rate has increased. So there is a disparity in care and there is a delay in treatment, negligence you can say, in the care of elderly people. And it has been noted that over the period of time, the patient delays from the chest pain to first medical contact has been unchanged to 2 hours in US. And I can tell you in our part of the world, it is 6 to 8 hours or 10 hours even. Patients don't care, they sleep in the night with the chest pain and next day, afternoon they present to the clinic in an OPD and they say, I had a pain last night. And then when you do the ECG, you find that he suffered an MI. And also even in US, the EMS transport was only 60%, which should be almost 100%. And there is a need for patient education. This is the data from, again, WHO. It's very interesting that in US, UK and Germany, and in the other countries of the Gulf and Arab world, the incidence of CAD and cerebrovascular disease and hypertensive heart disease is more than double. So you can understand that we are sitting on a volcano and which is rupturing time and again. This is a data from Gulf Race Registry, which was the first ACS registry in the Middle East, and which included 6 countries between 2006 and 2007. And the main highlight was that although there was a high rate of reperfusion, but it was significantly delayed and it was more in the form of thrombolytic therapy. Then came the Gulf Race 2 in the subsequent years, which highlighted that the patients in our region were of a younger age. There were high rates of metabolic syndrome, obesity is very rife, frequently late presentations, frequently poor acute management, low rates of revascularization, high rates of long-term mortality, and again, low utilization of emergency medical system. This slide is well known to everybody sitting in the room. It was a meta-analysis which was published in 2003, including 23 RCTs. At the turn of the century, people realized that primary PCI is the treatment of choice, and it sealed the fate for primary PCI permanently starting that year. So from 2003, when we decided that primary PCI should be the method of choice, and we are marching towards 2018, and where we are and what are we doing. The common pitfalls which you and me every day see in our hospitals is that we are very good in establishing networks, but we are not good in educating the patient that they should report immediately, and we are not very good in educating our first medical contact people how to recognize the MI early and how fast to act and how best to deliver the care. So there is frequently prolonged time to initial ECG, frequently atypical symptoms are missed, ECG is improperly interpreted, there is a failure to conduct serial ECGs if first ECG is normal, there is undue delay in reperfusion because of the reluctance and non-education of the first medical contacts. Sometimes the younger doctors think more of other diagnosis. They make a differential diagnosis even though the symptoms are very typical and ECG is very clear. And some people wait for cardiac markers even though there is classical acute coronary syndrome with chest pain and ECG changes. So these are the common pitfalls which we encounter in our daily practice. I will not go back with the guidelines in detail, but I'll just show that what do we have at the moment is a 2013 document from ACC and AHA for the management of STEMI, which further on was modified and a focus update was presented in 2015, especially on two aspects about aspiration thrombectomy, which was relegated to class 3 indication, and the second one is the multivessel PCI based on the number of trials, which was upgraded from class 3 to class 2B. After that, ACC came out with appropriateness criteria, modified appropriateness criteria, especially for acute coronary syndromes, and this was the last year, 2016. That's a very interesting document that they created 17 clinical scenarios, which you can say that them as indicators, and then the scenarios have been labeled as either appropriate care or maybe appropriate care or rarely appropriate care. So out of 17 scenarios or the indications, there are 10 were found to be appropriate, 6 may be appropriate, and only 1 as rarely appropriate. It means that most ACS patients finally would need intervention. And another important thing here is to see that out of 17 scenarios, only 3 are related to unstable angina and non-STEMI. Other 14 are dedicated to STEMI. So you can see the importance of the STEMI and the varied situations in which we deal with the STEMI. And then last but not the least is the ESC guideline, which was presented very recently, only 6 to 8 weeks before, with some real good changes in the thinking and the methodology of the treatment of STEMI. These are very, very important points to think. The yellow means it was class 2 indication or class 2A indication, which is converted now to green, that is class 1 indication, the radial access. Similarly, the DES preferred over BMS, been upgraded. The complete revascularization from 2B, it goes to 2A. Thrombus aspiration, it goes from yellow to none, almost 2B or 3. And then bivalirudine has also been downgraded. Enoxaparin has been given enough importance. Early hospital discharge has been considered at a higher evidence level, and oxygen therapy is not for universal use. In the last point in the slide is the TNK to be decided according to the dose by dose, according to the weight of the patient and age of the patient. And this also incorporated the additional lipid lowering therapy for LDL, which if it is still more than 70, and I mentioned about Cangrelor, use of Cangrelor. I mentioned about switch to potent P2Y12 inhibitor 48 hours after fibrinolysis, and early ticagrelor up to 36 months of extended use of dual antiplatelet therapy and use of polypills. And it also mentioned that routine use of deferred stenting, because there were some trials that you just do the revascularization and defer the stenting at a later stage for the infarctated artery, that has been downgraded almost to 3. And then the complete vascularization during index primary PCI in STEMI patients in shock based on the expert opinion. And then there are certain other points, the ECG criteria, and the MINOCA is a new terminology which is being used, myocardial infarction in non-obstructive coronary artery, and so forth, so on and so forth. The important thing here is the patient delays are still high. If you see, the total STEMI time involves starting with the patient and patient calling to the first medical contact, and then there is a flow chart that the FMC diagnoses the STEMI and then directs to the appropriate strategy depending on the circumstances. So we have, our networks have good control here, our networks have very poor control over here, that how best to bring the patient as quickly as possible. And our our current methodology also lacks somewhat here, because the dispatch of EMS, the point of first medical contact, all these are also importantly delayed. On the other hand, friends like Dr. Peter, he said they have excellent network in Belgrade for STEMI. I completely agree, this is after arrival. But a lot of the story goes before arrival, which is part of the total STEMI time. So we should work on this part also. This is what I mean in 2018, that we should be devoting our time to this part. There have been times described in this new guideline, and which I will summarize later. Obviously, we all know that in the first 3 hours, although primary PCI is preferred, but fibrinolysis is an effective option. But as the time passes more and more since the time of symptoms, the fibrinolysis becomes poorer and poorer in being efficacious. And after 48 hours, if patient is completely asymptomatic, no ischemia, then do not do PCI. This point also to be remembered and highlighted. The important times which we should teach to our fellows, our ER physicians, our ER doctors, not only the physician, the paramedical staffs involved in STEMI care at whatever stage, is that maximum time, turnaround time for ECG is 10 minutes, and you can transfer the patient to a STEMI care center for primary PCI if you think the expected delay is less than 120 minutes, and maximum time from STEMI diagnosis to wire crossing. Now they have removed the word door to needle, something like that. That word is, or door to balloon, that is being removed. It is wire crossing, less than 60 minutes, and if a transferred patient, then wire crossing should be in less than 90 minutes. The maximum time, this is also an important, interesting change, that fibrinolysis should be started within 10 minutes. It should be given within 10 minutes of the diagnosis made for STEMI. The failure or success of STEMI is decided between 60 to 90 minutes, and then even after fibrinolysis, the patient should undergo in 2 to 24 hours the angiography and revascularization. There are changes obviously in the procedural aspects of the primary PCI. Routine use of thrombus aspiration is not recommended. The routine use of deferred stenting is not recommended, and non-IRA strategy has been upgraded from class 3 to 2A. The fibrinolytic therapy involves one important thing, that use more enoxaparin, that will be better. That is one point of this guideline. And second point is, at the time of fibrinolysis, the second antiplatelet agent to be used is clopidogrel, but after 48 hours, you can convert into a more potent, newer antiplatelet agent. So key points have been summarized in this particular slide, that primary PCI, if expected delay is less than 120 minutes, to be preferred. The oxygen should only be given if the saturation is less than 90%. Radial approach and DES are preferred. Aspirin plus potent P2Y12 plus unfractionated is the choice during primary PCI, unlike previous consideration of bivalent. Aspirin plus clopidogrel plus enoxaparin is the cocktail for choice during fibrinolysis. Consider non-IRA PCI during the index admission. Early discharge to be contemplated. Extension of DRPT based on risk, ischemic versus bleeding, and additional lipid lowering if lipid therapy is not made. On the left panel in this slide, you will see my last presentation, because I keep doing presentations on STEMI, and on the right side you will see how it has changed after this guideline. So before it was, can you do primary PCI, do within 90 minutes. Now they say do within 60 minutes. Can you transfer within 120 minutes? It's it remains unchanged. And before the thrombolysis time was 30 minutes, now it is reduced to 10 minutes. It's a very important point. And if failed thrombolysis, it remains the same. After successful thrombolysis, there is a very minor change here that transfer for PCI within 3 to 24 hours. And now they say 2 to 24 hours in the new guidelines. And this door to needle and balloon concept has been dropped. And the reference point for treatment is first medical contact. So FMC has been highlighted repeatedly. So how do we increase the number of patients with timely access to the perfusion therapy? It involves multiple angles, starting with the patient, with the ambulance, with the emergencies, and then with the final treatment. And there are several stakeholders in this process, which includes the payer, the policymakers, the patient, the EMS, the STEMI referral, and the STEMI receiver. We as intervention cardiologists are very good in this. We are very quick. We finish the procedure within stipulated time, but we generally do not have much control on the other parts. So there are several barriers which are related to resources, financial resources, and lack of trained personnel. There is a barrier in the term of knowledge and awareness of us healthcare professionals as well as of the public, and there is a lack of organized framework. For example, we do not have good implementation of many frameworks in all the parts of the world, and then we do not have a clear political will in every part of the world. I'm not talking of any individual country. Some countries have done tremendous success in this. So we need to put all them together to overcome the barriers to reach to the care of STEMI in 2018. Remember the D's of dictum that you diagnose within 10 minutes. You decide whether thrombolysis or PCI to be done. You direct the patient appropriately to STEMI care center. You deliver the therapy, keep the defibrillator by the side, and use the drugs in a correct manner. So these are the D's of dictum in STEMI care. If a patient with chest pain deserves, it is his right that he should be treated as soon as possible with the most and best effective strategy, either with primary PCI. If not at all possible, then only thrombolytic therapy. No STEMI patient should be delayed or denied the reperfusion. It is a treatment of choice, obviously. STEMI is a treatment for the STEMI care, and this is how we try to do more than just doing angioplasty, is by educating people in different ways, which involve not only the teaching of the cardiologist, but the teaching of the all other paramedical staff, the GPs, the internists, the clinicians, to know more about it and to know more about the importance of timely treatment and timely direction. So this is a meeting. If anybody can join, most welcome on 17th November in Dubai. This will be the third symposium in this particular area. And thank you so much.